No, I'm not a host. Now you're the host.
Oh, okay.
Yeah.
All right. So I've already broadcasted it.
Yeah, I'm seeing that starting to join. Yeah.
Yeah. Okay, great. Now I think we are ready to start. We have, I just wish to let all the attendees and the panelists know that we are also live on our Facebook page, so they can as well let their colleagues who are not able to register in time join us on the live Facebook streaming. So once more, I want to thank all the attendees and the panelists for making time for this COVID-19 case management series 2 on IPC preparedness in healthcare settings. Today we have a panel of 4 speakers, and I will start by Lois Kihugi, who is a registered nurse. Lois is an infection prevention practitioner with over 15 years of experience in IPC. She's a member of the Infection Control Nurses Chapter of NNAK, and she's also a member of the Infection Prevention Network Kenya, and also the Global Infection Prevention Network. Lois, I hope I got that right. Our second panelist is Dr. Linus Ndegwa, who is the Program Manager, Infection Control and Antimicrobial Resistance Focal Person at CDC. He's the founder of Infection Prevention Network Kenya, that is IPNET-K, and a board member of the Infection Control Africa Network, and a board member of the International Federation of Infection Control. He is stationed here at CDC Kenya, Nairobi. Our third panelist for today is Dr. Kathy Mwangi, who is the director and founder of mHealth Kenya, which is a digital health solution platform, and she will be sharing on the Care for Carer platform and its integration into COVID-19 preparedness for healthcare workers. Finally, our last panelist is Jacinta Mokim, who is the National Treasurer for the National Nurses Association of Kenya, and she's currently undertaking her master's in medical surgical nursing. Jacinta is also a master infection prevention and control trainer of master TOT, and is currently leading the COVID-19 trainings for Machakos County. And myself, my name is Jemima Kibira, and I will be the moderator for this session for today. Thank you once again, our attendees and panelists, and I want to hand over the microphone to Lois Kihugi. Lois, over to you. Asante sana.
Hello. This is usually a very long presentation, which we allocate it with the Ministry of Health when we are training the healthcare workers. We allocate almost 2 hours, but I'll try to do it justice within the half an hour I'm given. Sorry, Jemima, my screen froze a bit. Let me
No problem.
retry.
Okay.
Okay. There you go. So there are 2 objectives that I would like us to meet at the end of this presentation. And I welcome all of you. As we walk through these slides, I would like at the end of it, all of us to at least understand the basic principles of cleaning and disinfection, and also to know how to perform effective cleaning and disinfection in healthcare settings. So I'll start with an introduction where I want to state that contaminated environment has been associated with transmission of healthcare associated pathogens. And cleaning and disinfection are actually components of standard precautions. You know, those standard precautions we talk about, like hand hygiene, and wearing PPE, it's part of it, that it's routine. It should be routine for us as healthcare workers. We should be able to make sure that the environment is well cleaned and disinfected, and the equipment we are using for the sake of reducing transmission of infections. The environment, it acts as a reservoir for pathogens, and this is mostly seen with the high touch areas where they are found to have high contamination with pathogens. So then I'll start by looking at the cleaning. And first of all, we need to know that cleaning is the first step of decontamination. I know we use this word decontamination interchangeably with disinfection. And basically, as per the guidelines by CDC, decontamination has 3 steps. That is cleaning, disinfection, or sterilization. So you either do cleaning and disinfection, or you do cleaning and sterilization. So it is always the first step, and it aims at removing organic matter or visible soil or dirt, for that matter, on the surface or the item you are cleaning. So it requires physical action of scrubbing using water and detergent, and then you rinse before you disinfect or sterilize. It's a necessary step which should be taken before disinfection or sterilization. A lot of emphasizing there that you cannot do disinfection before you clean. You cannot do sterilization before you clean whatever you are sterilizing. So then, what's disinfection? This is also a step in decontamination process, which eliminates as many microorganisms equipment and the environment could be having. Sorry, see my screen has dropped again. Sorry about that. So for disinfection, it is done on the environment or the equipment to eliminate as many microorganisms as possible, but this is a process that you cannot be able to eliminate spores. We know some of the microbes, they produce spores, which is a very hard stage of the microbes that they tend to go into, and it's quite persistent. And that step is mostly eliminated by heat and maybe sterilization in general. But we'll see there is high-level disinfection, which is able to eliminate some of these spores. Otherwise, disinfection is used mostly for semi-critical items and areas that we know we are conducting, we are carrying out procedures that could lead to contamination of the environment with body fluids and blood per se. So how are pathogens eliminated? There are few scientific processes that happen. For example, denaturing of proteins. This happens with the wet heat and ethylene oxide, which is a gas used to sterilize equipments, especially those that are supplied to hospitals like needles, syringes. They are usually sterilized using ethylene oxide. So what happens is the gas or the wet heat denatures the protein. We have oxidation, which happens with the dry heat and hydrogen peroxide. And then we have filtration. We have interruption of DNA synthesis by radiation. So for those who have adapted the method of cleaning or disinfecting the environment using radiation, this is what happens to the DNA of the microbes. There is also interference with protein synthesis. For example, what chlorine does, the bleach, and disruption of cell membranes, which is seen with phenol. So let's get into the various parts of cleaning and disinfection, and I'll start with the environment and equipment, then we move to linen, and we finish with utensils. And just think through, this is general principles of cleaning and disinfection, but we are giving them a touch of COVID-19. As far as types of cleaning methods are concerned, we have hotel cleaning, and we are talking about our environment, our healthcare facilities. There are those areas that you just need to do routine cleaning. That's what is referred to as hotel cleaning. Hospital cleaning is where you know there are procedures happening, there are patients, and you need to do what is referred to as hospital cleaning method. Special cleaning is where we have like isolation cases where patients have been confirmed to have infection, COVID-19, cholera. I am understanding that right now, Kajiado has many cholera cases. So the environment needs to be cleaned using special cleaning procedure. And in this case, we are talking about cleaning and disinfecting the environment. And finally, we have terminal cleaning, where we need supervision. The patient has either been discharged or transferred, and we need to make sure that not to assume the patient maybe didn't have an infection or was COVID positive but asymptomatic. That room needs to be supervised as it is being cleaned. So what are the principles of cleaning? Just to run through, we need to ensure that we are using products that are efficient, safe, and cost-effective. And cleaning should be performed routinely. And we need to choose methods and develop written cleaning schedules based on the type of the surface, the function of the area, and also how dirty it could be or contaminated for that matter. So it is important to use caution signs. Somebody may wonder, what does that have to do with IPC? Yes, sometimes you find somebody is cleaning an area, maybe a corridor or a room, and because they don't have signs, everybody is walking on the place they are cleaning before it is even dry. So that doesn't go well with principles of cleaning. You need to clean an area, keep it dry, and then it can be used and people can walk over it if it is a floor. The other thing is always clean before disinfection. The same principle of cleaning to ensure that you have removed all the dirt, so that whatever, if you are disinfecting, then the disinfectant will work better that way. So clean the least soiled, then you go to the most soiled later. And I'm glad we are all here. listening to this and walking through this together, because sometimes we have our cleaning staff who sometimes are not even considered for some of these trainings. So they end up working. We end up expecting them to do the work, but not realizing they don't know how to go about ensuring all these principles are adhered to. So cleaning also has to happen from high to low areas. Clean the tables and the chairs first, then you clean the floor. And of course, friction is needed to be able to remove the dirt. So no sweeping, dry sweeping in the hospital or healthcare facilities for that matter, and cleaning has to start from high surfaces. Like I had mentioned, we have to look at the high touch areas and ensure they are cleaned. And this is where supervision comes in handy, because sometimes the person may clean the whole door and not consider the door handle. And frequency also is determined by the risk of contamination. But as mentioned, it's important to clean the environment daily. Clean the cleaning tools, disinfect and dry before use. So what are some of the solutions we use? I know chlorine solution is vastly used, especially in our healthcare facilities, the public healthcare facilities. Sometimes it is the only disinfectant around us. But let's remember, environment can be cleaned and safely be safe for us by using just the detergent. But based on the assessment of the contamination, we could use 0.5 chlorine solution, which is made from chlorine products. And there are various chlorine products, and the most common is sodium hypochlorite, what we commonly refer to as JIC. There are others which are calcium and also sodium dichlorocyclinurate tablets. And we have also alcohol, ethyl or isopropyl, which is also used. It is an antiseptic, but it can be used for low-level disinfections. And we also have hydrogen peroxide as one of the products. Considerations for chlorine. We have chlorine being used in our public hospitals, but we need to adhere to the considerations that are there for us to follow so that it can help us perform an effective job on the cleaning. And one of these considerations is for us to remember that chlorine loses strength with time. And so it needs to be prepared afresh every day. And it needs to be kept away from the sunlight, because sunlight weakens it. And we need to store it in a closed container, because it forms fumes and it can contaminate or pollute the environment. And as it fumes into the environment, then it means it loses its potency faster. So how do we carry out the preparation for chlorine? Commonly, we know our support staff, what they do, they just take chlorine solution and they add to the water without caring how much. But ideally, they should perform hand hygiene and put on the protective gear, mask because of the fumes, gloves and apron. And then they mix chlorine with water. And they must stir the chlorine, especially with the powder one, so that it can mix well. Always wait for 30 minutes before use. So many a times chlorine is prepared and it's put to work. This should not happen, because it works better after it is given time to mix well and settle. And there should be a label on the container, which is 0.5% chlorine. And this percent referred here is for the general work. It's the most preferred and most effective and least hazardous. And the date should be indicated on the container and the time it is prepared, so that the person can remember when to prepare the next fresh supply. Otherwise, we have two formulas that are shared for when you have your chlorine from the shop in liquid and when you have your chlorine from the shop in solid, maybe powder or tablets. And these formulas here, as you can see, they take you through on how to ensure that you end up with the right concentration of your supply. And this other slide is showing us the preparation for chlorine solution when you have powder or tablets to get to the concentration that you need. And you can see here 0.5. So you have to look at the concentration of your product from the shop. How does it come packaged? Is what percentage? So cleaning tools and items include personal protective equipment. So if you have cleaners in your facility, ensure they have all these tools. The cleaning cart or mopping bucket, at least 2, floor mop. Why at least 2? Because you need one for cleaning the dirt and the other one for rinsing. Floor mop, small bucket or a bowl for cleaning the surfaces, and also cleaning clothes and cleaning solution. So general cleaning entails just putting on gloves, performing hand hygiene, putting on gloves and the rest of the required PPE, and cleaning to start with equipment and finish with the floor, cleaning to start cleaning each of the items, and then if it needs disinfection, then you do the disinfection later. For those that need disinfection, we need to consider contact time of the product you are using as a disinfectant. If it is chlorine, then you give it 10 minutes and then clean to rinse the chlorine off, the residues, and then ensure you leave it to dry, remove your PPE and wash your hands. Cleaning an isolation room. Wherever we are having our patients isolated, we need to ensure that cleaning is happening because there is a risk of pathogens.
We can't hear Lois.
Hi,
Have we
Lois.
lost Lois?
Yeah.
Yes,
I can see that like we've lost Lois. Okay, we'll be able to get in touch with her. In the meantime, I'll request Dr. Linus to take over. Dr. Linus, over to you. And let me see how we can get Lois back. Probably she's having an internet connection problem. Dr. Linus, over.
Thank you, Jemima. Let me try to. Can you see my screen?
Yes, we can see them. You can put them on slide share.
Thanks, that's right, yeah.
Okay.
All right. So looks like you can't see me because the host has disabled. I'll just continue the way it is, which is okay too. Good afternoon, and thanks for inviting me to share with us IPC preparedness, readiness, and the response in healthcare settings. I must say that first, that this is quite a big topic to be covered within the few minutes that we have been given, but I hope I can share some thoughts and a few tips that really tries to address this topic. But I believe that when we get another chance, we can go deeper into it and be able to look into the situations as the organizers envisaged that as members, we should be able to understand. So I'll just look at these two outline the present state preparedness and strategies to limit transmission in the healthcare setting. And I hope that we can hear me well, Jawera and the team.
Yes, we can.
Thanks. So when we talk about preparedness as the topic that I was given to look into, I just want to take us back and say that as Kenya, as a country, we started working with the Ministry of Health from the CDC perspective, making sure that at least learning from the previous lessons. So derived from the pandemic influenza plan that was written in 2010, immediately after the pandemic of influenza in 2009, the Ministry of Health actually set up an influenza unit, and we were working together with them, and we prepared a pandemic plan. And that pandemic plan, we actually started updating it last year, and it was updated in 2019, which and some various operational strategies that I would like to take us through briefly. One was really about the case management, talking about the institutional care, and that plan is there, looking at the general patient and the patients who may be needing specialized respiratory support and community care. And that's why I would say that I would really support the government of Kenya and really allude what the steps that we've been able to do is basically because this pandemic plan was already in place, and as a country, we were able to dive in, and those are the few things that we are able to put in place, and therefore, as we continue learning with this virus, more of this get to be put in place. So the other aspect was the infection prevention and control as part of the preparedness. And I can tell you that the Ministry of Health, supported by the CDC, developed the IPC guidelines, IPC policy, excuse me, and started working together to establish IPC focal points in the various counties and institutionalizing the IPC. And I know this pandemic actually got the Ministry of Health and especially the Patient and Safety Department working in establishing that. But I can't say that most of us, as you may understand, that we didn't take this IPC seriously then, but I really appreciate that now people have now started to understand that IPC is a very important component in the patient care. So within the plan, we also have the pandemic influenza vaccination plan. And so that has been going on. And so this also prepares us as a country, even as the COVID vaccination is being developed. And by the time it comes to Kenya, then we'll have, as you can see in the bullet 4, the National Deployment and Vaccination Plan. It's already in place, so that will not get us by surprise. I wanted just to share with that in terms of the preparedness. Now, I want to shift gear and just look at this slide, which we compiled, looking at the situation that we are in. If you look at this line, we are looking at the cumulative number of people who have been found to be positive of the virus here in Kenya in terms of case load. And as you see, this the number of deaths and the cumulative. And then when you look at the healthcare worker infection by week, this data is really up to the week of 29. you can see the number of healthcare workers who are getting affected is quite on the increase. Again, what we learned from this is that, as you see, the case load increases, so does the healthcare worker infection did increase, and the proportion of the healthcare workers among the cases is about 4%, which is really quite an alarming. So, but just moving on, if you look at the healthcare workers, what I was mentioning is per the general population, in terms of infection, it's quite disproportionate. And you can see the blue bar is actually showing the infection among the healthcare workers cases per 100,000. And the blue bar is for the general population. And this orange bar, you can see it for the healthcare workers, which really translate to us that healthcare workers are more infected almost 30 times, which is really quite unacceptable and an alarming kind of situation. So when you look at that data, what really comes into your mind? And these are some of the things that I would like us really to look through in the next few minutes, because again, this helps us to understand that the importance of having a strong IPC program in this country, within the health care system and within the facilities. So that brings me to what is infection prevention and control. This is basically a scientific approach with practical solutions that are actually designed to prevent harm that may be caused by infection, both to the patient and the healthcare workers. It is basically grounded in principles of infectious disease, epidemiology, social science, and health system strengthening. And it's basically rooted within the patient safety and health service quality. So we all know about this virus, but I don't want to dwell much on this because we've learned much about it. Yet we are still learning more. But basically what I wanted to mention here is for us to understand, there are main key things that as healthcare workers we need to understand, that this virus is basically through droplets and then airborne. Now, when I talk about airborne, I want to be very specific that it's through aerosol generating procedures that are normally performed within the healthcare system. And these are some of things that can bring about the airborne transmission. And this has connotation in terms of the type of PPE that we need to wear when performing these tasks. So basically this slide just wanted to show you that so far as knowledge is increasing concerning this virus, we've got to understand that it is a systemic kind of an infection affecting every part of the body, starting from the entry point, which is the respiratory system, going to the GIT where it causes diarrhea, causes nausea and vomiting, and of course going to the whole system where it causes some the cytokine storm, and of course causing to organ failures. So it's just something that I wanted us to look at. But then looking at all those situations, what are the various levels of response do we need to put in place, and what have we understood about it? So we have what we would call the response interventions and the epidemic phases. So of course, we know about the introduction of in Kenya, when we heard about it, when it was circulating in China. Of course, sometimes during those times, of course, we started updating our preparedness plan and looking at it. But to many of us, we didn't think that it would come soon to this country. And that's what we're talking about, anticipation and the introduction of the or emergence of the virus. Then there's the early detection. And now we hand that phase of early detection, and we are actually in this phase of localized transmission. And within this localized transmission, it's now we need to ensure that really we are isolating the positive cases, especially in the healthcare facilities, having quarantine, having intense contact tracing, testing, putting the measures like social distancing, cough etiquette in place. And of course, we move then to the amplification period, which actually we are almost there, whereby there's the isolation of positives in the community, and that's why we have the guidelines on the managing of these patients in the community setup, and increasing the intense contact tracing and testing. Of course, we've had some partial lockdown, but if this intense can really go up without most of our colleagues and the Kenyans putting measures in place, then of course, this may end up into a total lockdown, and really these are some of the things that we want to make sure that we avoid. And then we get into the other part of the containment and then reduce transmission. Now, looking at that in terms of healthcare work and into our facility, in terms of trying to build within the topic, is that we need to understand the chain of infection. We need to know what needs to be put in place. This is an infectious agent, which is a virus that we need to understand, and we are still in the learning perspective of it. So we don't have known antimicrobial therapies for it now, but we have what Lois was talking about, disinfection and sterilization to prevent this agent from moving. Then we have the reservoir. Where is this virus found? We need to put in the engineering controls. We need to have the environmental measures, that is screening and disinfection, put in place. And I'll take more in terms of talking about engineering controls, which are very important for us. Then we need to look at the port of exit. And this virus, the port of exit, we know it is sneezing. So that's why hand hygiene is being emphasized. And the way we dispose of, we are talking about putting on the mask. How are we disposing these masks that we are putting? Because that could be a source of infection. The other is the mode of transmission. And of course, for this situation, is that we need to put measures, again, these engineering controls to prevent transmission from one person to the next, hand hygiene. And then the port of entry, and this is hand hygiene, and where we are also talking about putting on masks. And of course, the susceptible host. So having just ran through that, then we need to look at the hierarchy of control. And this really I would like to emphasize more, because to many of our colleagues that I've talked to and where we are, is that we think that PP is the most important aspect in the fight within the healthcare setting to prevent the healthcare workers in terms of getting this infection. But in reality, and as I say, the principles of infection control are guided by scientific methods that are known. So if you look at it, PPE is the least effective compared in the hierarchy of control. The best is actually eliminating the pathogen. Now, the pathogen is already here with us, so it becomes a bit difficult to physically remove it. So if we can't physically remove it, then we move to the next stage, which is substitution. How can we substitute this agent called the coronavirus from affecting us? And of course, the other issue is engineering controls. And one of the engineering controls is trying to isolate those people who are infected and trying to put measures within our healthcare system so that we are able to ensure that those who don't have are not infected. Secondly, as we have already known, 80% of the people are not symptomatic. So you may never know who is having this disease. So we have to put engineering and again, administrative controls, the way we do our work. So we have actually, as healthcare system that we know ourselves of Kenya, the most important thing is administrative control. We have actually to change the way we work in our healthcare setting. The way we used to come with a dust coat, moving from one department to another, we have actually to change that. So looking a bit more details in this is that when we talk about engineering controls is the infrastructure. Some of the consultation rooms that I've seen in our setup, the ventilation is quite poor. And that's really where it requires administration so that we improve the aeration in those consultation rooms to reduce the number of healthcare workers who are being infected. Of course, having water and sanitation. Sometimes it has really baffled me. You find that in a consultation room, there's a tap for hand washing, and then that in one way or the other, it gets blocked. And it would take a whole month or even several months for either the plumber or whoever is responsible to actually make that water to flow. And these are some of the very small critical things that we need to put in place and ensure that we have water, we have sanitizers in place. And the other thing is creating barriers. In terms of administrative controls, is policies, regulations, and guidelines. I want to really commend the Ministry of Health has done a commendable job. We have a lot of policies that have been put out there. They are on the ministry website, but I can tell you from a few that I've interacted with, some of them, they don't know about these policies. They don't know about these guidelines in terms of IPC and even more specific for this COVID-19. The other important aspect in staff administrative control is staff training. If staffs have not been trained on IPC measures, what do they need to do? Then it gives them that idea that they are not well protected. They panic when they hear they have come in contact or there's a patient suspicious, and that really prompts them to infect themselves. And these are some of the key things that needs to be put in place. Then having a strong IPC committees within our counties and within the health, our health facilities. Because some of us, we've left some of these IPC focal person as the only person. In these committees, when we call, you may find even the senior members of staff who have been allocated to these committees, they never attend. A case in hand, I know sometimes I was trying to give a topic on hand hygiene in one of the facilities, but some of those senior members of staff didn't turn up at that time. And it was just before this COVID came in. But when it came and it attacked us, they were now looking for us to train them on hand hygiene. So what I'm trying to bring here is that when there's opportunity, let's seize the opportunity, let's empower ourselves with knowledge as we are doing now so that we are better prepared. IPC is a critical component for healthcare worker safety, for the way we work in our facilities. The other issues is the environmental controls, and that is exactly where Lois was talking. I don't want to dwell much on that. So when we talk about IPC practices, we have the standard precautions and addition, or what we call transmission of these precautions. Now, standard precautions is hand hygiene, proper PPE use, safe waste management, safe injection practices, because these are some of the things that expose us, put us other care workers at risk. Then cleaning and disinfection, and respiratory hygiene. Now, additional transmission is really these additional precautions that we need to put in place once we know what pathogens are we dealing with. Like now we know COVID-19 virus, SARS-CoV, is transmitted by droplets and or aerosol generated. So what precautions do we need to put in place? And this brings me into this line that more focusing, we need to have our healthcare workers and to know what patient we are dealing with in terms of preventive and screening, and then have a focused IPC approach, whereby we are able to identify high risk departments, high risk areas for healthcare workers within our system, and then implement a collective approach so that we are able to protect our healthcare workers. And this requires training of the healthcare workers in terms of human resources and also increasing the number, because if I'm the only healthcare workers taking care of 40 patients, 50 patients, then that puts me even at higher risk of contracting the virus. The other thing is about the structures for isolation. Now, from the data that I shared earlier, we went deeper to slightly look at it, and we found that the asymptomatic infected healthcare workers can actually be super emitters and transmitters of this COVID-19 to other patients. And as you can see on my right-hand bottom side, this was a slide that I borrowed from a presentation that was taking place again. This shows that from Niger, whereby one of the doctors actually was able to transmit or cause this character to 50 other healthcare workers. Now, how did this come about? If you look at the top right corner, you can see if as a healthcare worker, and this is, we have about, if you are attending to 10 patients, you have about 90 routes of way of interacting with that patient and transmitting the infection or getting the infection from any of those patients that you are attending to, if per chance you didn't take any precaution. And we need to understand one of the key important things is 5 moments of hand hygiene. Now, when we talk about 5 moments of hand hygiene, it becomes a bit difficult for most healthcare workers. We need to wash our hands before contact with any patient. But most of us, we do this after contact with the patient. But before, it's very important. And before you go to the next patient, you need really to cut the chain of infection by hand sanitizing or hand washing after every patient touch. And so this slide really top right, as you can see there is, if you are attending to 10 patients, how many contact routes that you may be having. So for us to be able to really respond to this, then we need to do a risk assessment. A risk assessment for the healthcare workers is very, very important. And this slide, I'm just sharing it from the data that, the little data that we have gotten of the current situation, which I had shared earlier, which shows that if you look at these patient healthcare workers, those who are low risk and they were tested, they actually, you find that majority of them are those who are low risk. In terms of the score of assessing their risk, then their turning of positive was quite low. But those who had higher risk score, then they were actually 10 times more likely to have a positive PCR test. So just this is my last time, and I want to, as I finish, just to bring us to understand that the importance of identification and management of healthcare workers, we need to have an active strategy whereby we have healthcare work education in terms of masking, social distance, PPE, respiratory etiquette, and hand hygiene. And then, of course, encourage healthcare workers about self-assessment and encourage the issue about self-reporting and issue about screening of all healthcare workers at entry in each shift. I was just impressed in another facility I went yesterday. And in that facility, it doesn't matter who you are, whether you are a visitor, whether you are a patient, whether you are healthcare workers, and it's a public facility, a government facility. You have to be screened. You have to actually record your details. They have quite a robust way of screening anyone entering the gate. And this is very important for us as healthcare workers and the facilities that we are in. So healthcare workers need also to report in case of breach of PPE. And this is where we are talking about risk assessment. And on that note, I would like to really stop there and invite my colleague, Dr. Kathy, so that she can share with you the thoughts and what we are proposing and putting in place to help us as healthcare workers in terms of self-assessment and screening and reporting so that we are able to protect our healthcare workers. So Kathy, over to you so that you can share with us about the screening and C4C. I'll stop my sharing. Thanks.
Thank you very much, Dr. Linus. That was very, very insightful. We have a few questions for you, so please stay on the line. Dr. Kathy, I will kindly request, because Lois had dropped the call, she had a bit of a blackout. We let her finish. Lois, you have 5 minutes so that Dr. Kathy can take over. So Dr. Kathy, kindly, if you give Lois a few minutes to finish up, and then you take over. Asante sana.
All right.
Thank you so much, Jemima, and sorry for having dropped and left you people. I'm going to take over and brush through the remaining slides because the principle is the same. Here I had started talking about cleaning and disinfection of isolation room. The most emphasis...
You want to put on screen share, on the slide, yes, sorry? Yes. Thank you.
Thank you. The thing to emphasize here is on supervision. So when we are cleaning such a room, we don't just put the individual who is cleaning and leave them to do the work they are going to do. They need to be supervised for us to be sure that they have done a good job. And for isolation, if it's there's need to change the equipment, the beddings and all that, then has to be done with the supervision to avoid contamination or mixing with the equipment and linen from other areas. Just to mention on other equipment, medical devices, basically we look at the item. What is the item used for? Does it need disinfection or it just needs cleaning? And if it needs cleaning, how can we clean it safely without maybe spoiling it? So there are all those things to look around and out for, and that's why I'm saying we need to support our cleaning staff. We can't just leave them to clean and we expect the work to be perfect. And we've got to remember that some of our items, our environment may look very clean, but is it clean as far as microbiology is concerned? Are we having clean surfaces, but they are all contaminated with pathogens? Because that is possible. Basically, these are the principles of disinfection, more or less the same, performing hand hygiene and ensuring that if you are doing disinfection, follow the contact time for that particular product. And the product needs to be rinsed after disinfection for 10 minutes if you are using chlorine solution. And it needs to be air dried if it's a device. If it's an environment, you rinse and leave it to dry before people start working on the surface. So the others two parts follows the same principle of cleaning, disinfection, and sterilization. And in this case, looking at the linen, linen has to be handled carefully. And for COVID-19, I want to say there is no much risk unless that person is drooling with the mucus and all that, but linen has to be handled carefully and laundered separately. And we know there is linen that does not look dirty. It has been used, but it doesn't look dirty. That we categorize it separately, as opposed to the linen that is soiled and that is wet with body fluids and other excretions from the body. So if we are having a patient who is admitted or who is isolated with COVID-19, the linen, we consider it infected linen. We have to handle it with care, even if the risk is considered minimal, especially if the person is not having oozes from their body. So linen has to be collected separately and put in bags and carried in a covered container to the laundry. So this is still about cleaning, transportation, and in this case we are saying use a deep sink or container for sluicing. I know some facilities have improvised for linen cleaning because you cannot use a shallow sink for cleaning. And if you have to sluice, it has to be done in the laundry. For disinfection part of the linen, we need to clean the linen at a temperature of 70 to 90 degrees. And if it's manual cleaning, which is normally discouraged, but we understand some facilities don't have washing machines, that they could take their linen through high temperatures, 70 to 90 degrees for 10 minutes. Then they need to use chlorine solution, this time 0.05 for 10 minutes. Or they use the boiling water at 90 degrees for 30 minutes. And then rinse the linen and air dry it. Pillows, mattresses, and everything that is fluffy and cushioned needs to be discarded if it is contaminated. There is no way you will be able to clean that and have it safe. And any linen that is clean needs to be stored safely away from that. And of course, we have the occupational health safety consideration for our healthcare workers, like having them given hepatitis B vaccine so that they are protected from hepatitis B virus infection. So for utensils, again, this is an area that, especially with COVID-19, the risk is minimal, but you want to be careful by using maybe a dishwasher to ensure that the dishes are well cleaned. Or if you are using manual, use 3 sinks where you have a sink or bowls, where you have one for removing the food products, the remaining food particles, and then one for soap, and the third one for rinsing. And for isolation area, it's preferred disposable cutlery and other utensils. And this is what I've just explained, but put in a table for dishwashing and for manual washing. And let's remember, if you use any disinfectant on your dishes, remember to rinse and air dry. Thank you.
Thank you very much, Lois. That was quite informative and very elaborate. We will be taking questions at the end, so please keep dropping them on the Q&A section. So now I'll give Dr. Kathy. Karibu sana.
Thank you. I hope you can view my screen. So my name is Kathy Mwangi. Great. My name is Dr. Kathy Mwangi. I will be presenting on the care for the carer system. And just to start with a very brief introduction, I work for mHealth Kenya, and mHealth Kenya has been working closely with the Ministry of Health with the support of CDC. And what we've been doing is really providing technical assistance and coming up with innovations that we end up implementing in partnership with either Ministry of Health partners or units or departments. But our goal is to come up with innovations that will support public health initiatives, a lot of our work being within the HIV space. Care for the Carer, which I'm discussing today, is a mobile and web-based application that aims to improve safety and capacity building for healthcare workers. It also has a communication platform which healthcare workers can receive health information on their safety against maybe bloodborne pathogens and other infectious diseases. We've done more of the work that we've been doing within the HIV space. And recently we upgraded or made some enhancements into the platform to support COVID-19. The platform provides a confidential platform. And the idea is to support the healthcare workers in reporting exposures, and then certain follow-ups and reminder messaging is sent to the healthcare workers using the protocols that have been approved by the Ministry of Health. And the goal is to just make sure that there is adherence of PEP. So based on the experience that we have had previously using that module, we used that same logic to come up with a COVID-19 platform that would then support healthcare workers to report, and hopefully we can support them in reminding them either to report their symptoms and all that, which I'll explain further. This is just a process flow, or it might look a bit busy, but I'll explain. On your left-hand side is the dashboards. And these dashboards are used either at the facility level or at the partner level to either post resources or tools or guidelines. It can also be used to upload the healthcare workers. You can use an Excel spreadsheet to upload healthcare workers who have consented to use the platform. And so that would be the dashboards that would be used. Now, how it works is that the healthcare workers might be uploaded into the platform, but they have to consent and they have to complete the registration themselves because they have to want to use the platform. And within the platform, we provide for resources and tools. They are able to report either vaccines, vaccinations that they have had, provide maybe even they can diarize a reminder if they want a reminder to go for a vaccine or for their annual physicals. And it also has alerts and notifications. Now, depending on how you are registered, if I was a healthcare worker registered within Kenyatta National Hospital, for example, Kenyatta National Hospital could have some messaging that they would want to share with me. Then I would be able to receive those messages, but those would be customized and broadcasted by certain people with access levels. And within the system, to the right-hand side, there is a dashboard and analytics that are very, that would provide certain information. And those analytics are aggregate data. They do not give any personal or demographic information of anybody who reports. They will give how many healthcare workers, and I'll show you a sample of a report that could be pulled from that is all aggregate data. The value proposition, what does this system have? We do have a bulk registration, and how this has been used is where a partner probably has healthcare workers that they support, and they would want to be able to communicate with them or provide guidelines to them or certain tools that they would want to share with them. So that you can register maybe 100 healthcare workers within the platform that are within a partnership or a facility, and they are registered within the platform as belonging to maybe facility X or sub-county X or county X or county Y. And now what would happen is that you can send broadcast messaging to them. So it provides an easier, faster, cost-effective communication to all members at the facility, partner level, county level, national level, using SMS at a one go. So in a case where there are exposures, like in this period of COVID-19, we are all learning, and there is always something new. This is a field that can be used to send healthcare workers some new message or some new communication. Maybe the symptoms have changed, and now, besides the symptoms we've been looking at, there is something new. Would you want the healthcare workers to know? And then there is a resource center within the platform. And the resource center then provides materials, guidelines, protocols that healthcare workers can access. And you can give them, the healthcare workers, depending on how they are enrolled and what organizations they're registered as, there is information they can receive at maybe at a national level that goes to all healthcare workers, but you can also send resources or guidelines that are specific to different cadres. So if you just want these resources to be available to just nurses, then you can do that. If you want these resources to be available to just doctors, it is possible to do that. And so it has a resource center that is also linked to some e-learning platforms. Currently, we are working also in partnership with University of San Francisco and NASCOP, where healthcare workers can access certain training tools that are provided through that partnership. But that resource center can be expanded and to include other e-learning platforms. Then there is exposure reporting. For a while, we've been working in partnership with CDC and NASCOP for healthcare workers to report when they have exposures for HIV. And it is this platform that we used to enhance it for COVID-19 exposures. And this, what it does is that if you report, it just has confidential reminders based on the protocols. But for now, that module is also linked to another platform that is currently being used for COVID-19, which I'll also show. But it is supposed to support the healthcare workers so that they are being able to, they are followed up when they get exposed to either HIV or COVID-19. There's another platform. We also know that healthcare workers are required either sometimes to go through certain or to have certain immunizations. But we also know that healthcare workers can be very busy. So where you have immunizations that are you're supposed to get 2 or 3 doses, when you get one, you forget when you are supposed to get the other. You could diarize that on the platform, and it reminds you the next time you are supposed to get your dosage, so that you just remember and then you go and see. So it is quite agile, and it is able to do that. But then finally, it also has dashboards, and these dashboards then help for real-time visualization of data and reports. And again, the dashboard is all aggregate data. It does not provide for any healthcare information or any personal information, but it is a dashboard that would provide for assistance maybe at a county level or a partner level or a ministry level in terms of policy decision making. And so those are some of the value proposition on the platform. So what have we done with this platform during this period of COVID-19? What we've done is that we've added information on COVID-19 through the platform, where healthcare workers can receive training. Any new materials that come across that we receive, we provide them on the platform. So anybody enrolled into the C4C platform can have access to that. And it is always open for new information. We also have access to some training that NASCOP does. They usually do the echo training. It is linked to that. So if there's some training that has been done and you would want to have access to that, you can have it through the platform. There is also links to the Ministry of Health websites, resources, tools, any other additional guidelines that would be required that you would wish would reach the healthcare workers fast enough. Sometimes you have resources or you have guidelines that have been printed and they need to be shipped to where the healthcare workers are. We can have those available on the platform where they can download them and can have access to them at any time, either on their tablets or their phones. And then there is the reporting and monitoring of exposures. And now we've added for COVID-19 among healthcare workers. But this system is also linked to another system, Jitenge system, that has been used during this COVID-19 period for self-quarantine and home-based care and isolation module. So what the Care for the Carer platform would do is that the healthcare workers would report the exposure, and we would be able to know what cadre is reported the exposure. But within the C4C platform, we may not necessarily be able to continue monitoring that healthcare workers if they do go for isolation or if they do go for home-based care. What we do is that we have integrated with the Jitenge system so that the moment you need self-isolation, or you need home-based care, or you need to go on the 14-day quarantine, then you're moved to the Jitenge platform. And at that point, Jitenge picks up for you to be able to report the 14-day symptoms on a daily basis until your 14-day quarantine period is over. So just to show a little bit on this, just some screenshots on how it looks like. These are just a few, but if you were on the platform and you are enrolled into the C4C, there would be a certain screen that would allow you to report exposures. I didn't go into too many details because of time, but this is where a healthcare worker who is registered in the platform would report an exposure. So you have either COVID-19 exposure reporter, or you can report other exposures. And you're required to enter your ID. And I know in some cases, people do not necessarily enter their ID, and the probable date of exposure, because, and now you have the county, sub-county, and ward. What this would help is to know how many exposures are coming from maybe a certain county or sub-county. It would help in tracking the numbers at the county or sub-county level. What it also does is, if you do report the exposure, it will ask what kind of PPEs were worn during the exposure. And you would just click on that. And what that does is that it would help in our reports to know, how many people were exposed and what PPEs did they have, just for data, to enrich the data. And from a healthcare worker perspective, remember, this is a personalized diary, so to speak. So you would be able to have track of how many times you've actually reported an exposure. Again, this is very personalized. You have your passwords and user IDs, which definitely you need to keep confidential. But at the bottom here, it shows, this is where you have your exposures. If you want to report immunizations, that's at the bottom here. And this is, you have resources. That's where you would access your resources. Now at the dashboard level, and again, this dashboard access is given to just the people who need to view that. But when you log in, you would not see any person's information other than how many healthcare workers have reported exposures, what was their cadre, what PPEs were they wearing. So at this level on the dashboard, those are the kind of reports you would see. Now, again, on the platform, this just shows where you report the exposure from the app. If you're reporting immunizations, at the bottom there, you have resources. And to the right, that is where, if you need to go for isolation, a 14-day isolation because you've been exposed, you would click on that and it would automatically link you to the Jitenge system that then starts monitoring you for the next 14 days. It is currently being used by trackers. It has a module that's being used for self-quarantine. It started at a facility level quarantine management, but right now it's also at the point of entry in the borders. This is just some of the numbers so far. We've been implementing this, but as we speak right now, we have 9,478 healthcare workers registered on the platform. The COVID-19 module has not yet been implemented. So the exposures you see there are just HIV exposures and not COVID exposures. The COVID exposures, though the module is there and it's complete, we've not started the implementation of those COVID reporting. And the kind of reports you would pull from the platform that we were talking about in terms of aggregate data. These are just some of the numbers. So we imagine, you know, if we were to look at COVID-19 reports, you would be able to tell how many people are reporting exposures, how many health doctors have reported the exposures, how many nurses, and how many have been transferred to Jitenge for either self-isolation and beyond. But there are so many other reports that you can pull. This was just one example that I thought I should share. And because of time, I think I will stop there, just to acknowledge the Ministry of Health and the US government who have been supporting our projects. And I think that's it. Over. Thank you.
Thank you very much, Dr. Kathy. That was quite elaborate. Maybe we'll have a few questions for you once our last panelist for the day has her session. So Jacinta, this is the internet is yours. These days you say the internet, not the floor. Jacinta, karibu.
Thank you very much, Jemima. Let me take this opportunity also to thank my fellow panelists, Madam Lois, Dr. Linus, and Kathy. Fellow professionals, allow me to begin by appreciating and thanking our well wishes to the professionals who have contracted COVID-19 in their line of duty.
Jacinta, could I ask Dr.
Yes.
Kathy to stop sharing?
Thank you.
Yeah. All right. Thank you.
Okay, so I began by thanking each one of us for taking time definitely in the session. Quite informative. My acknowledgement goes to Dr. Linus, Madam Lois, and Madam Kathy. Very pertinent issues that you brought to the people who are in the session. And again, I'd like to appreciate and send my well wishes to the people, rather professionals who have contracted COVID-19 in their lives of duty. Definitely, they are our heroes and heroines. Fellow professionals, we all agree that the journey has just begun. We should prepare ourselves for a hard task ahead. Actually, Dr. Linus has just told us that the attack rate for the health workers is actually 30% compared to the general population. So we definitely have no choice. We have no choice but to appreciate, encourage, and embrace one another. And again, we have no choice but to protect one another, whatever cadre we are in, and whatever position we are holding in the health system. I remember again, Dr. Linus has raised the issue that healthcare facilities, the epicenters, can actually become epicenters if precautions are not taken. So what is my role? What is your role? What is the role of the other health worker in ensuring that we protect ourselves, we protect our patients, and we even protect our family members? Every one of us has a role to play, and if each one of us plays their role, definitely at the end of the day, we'll be there rejoicing and celebrating the elimination of the COVID-19 virus. Definitely, COVID-19 disease has been a communicable disease. Infection prevention is the only way that we can deal with it. And Lois has taken us through the cleaning and disinfection, which I think most of us take for granted. Just cleaning the surface that you're working on.
You can come closer to your mic. I think you're a bit, just come closer to the mic, Asante.
You can hear me now?
Yeah.
Yeah, so I was saying that being a communicable disease, infection prevention is the way to go. We were not able to eliminate, or up to now we have not been able to eliminate the virus. And actually we are at the least level, which is the PPE, use of the PPE. So we really have to ensure that the PPE that we are using is of quality, the PPE that we are using is of standard, the PPE that we are using, we are consistently using the PPE. How do we do? How do we do? Because at the end of the day, we may don't so well, but infect ourselves when we are dosing off. So this is something that we need to encourage our professionals on practice. Remember that in the what Linus has elaborated on the response intervention, I think right now we are at the amplification phase. We are actually, the virus has amplified, and definitely the health worker is going to be overwhelmed. So what is my role when I become overwhelmed? How do I react? Do I sit in my cocoon and just get depressed? Do I share my emotions with somebody else? Because the moment again we get overwhelmed, the risk of infecting ourselves, the chances are very, very, very high. So again, we need to speak, we need to talk to the other person. And all about infection control, we just need to break the chain of transmission. Remember, from the point of entry to the point of exit to the reservoir. We just need to break a point so that again now the infection does not become a vicious cycle. Definitely do PPEs, drugs, psychotherapy, nutrition, hand hygiene, and of course ensuring that the infrastructure that we have is of standard. The other thing is on ensuring that whatever we do, we are able to do it in the right way. So how prepared are we as a country or even as counties or health facilities? Again, the first step in preparedness is prevention. The question we should be asking ourselves is, how prepared am I? What is my role in the preparedness? Have I played my role in ensuring that, have I prepared myself in ensuring that everything is in place? As a manager, as a practitioner, as a family member, do I have a role to play in ensuring that we are well prepared in working against this pandemic? I always tell people that before you even handle a COVID patient, actually let us inquire from our colleagues. Let's have critiques from our colleagues. Am I protected? So the other time, the minister, the CS was saying that if you save me, I'm going to save you. So we need to save our colleagues because it might reach a point that colleagues, most of the professionals are infected. So who is going to assist the patient, or who is even going to tend to the professional who is affected? So definitely we do not have a choice but to ensure that we protect ourselves and we protect others. Today's webinar is actually among the series of online webinars that will be taking place every Thursday at 2 p.m. We started the webinars last week with home isolation guidelines for COVID-19. And then we also have on-site trainings, physical trainings, which have started in various counties and shall be done throughout the country. And then we also have to understand or to appreciate that this is a partnership between the National Nurses Association of Kenya, the Kenya Medical Association, the Kenya Clinical Officers Association, and the Doctors Union. Definitely on building capacity on healthcare professionals for COVID-19. Again, to note is that we also have mental health webinars that are running every Tuesday at around 7 p.m. A very key area that we as professionals need to be and brought aboard on the updates. The last and not the least, I would like to challenge us as professionals on sharpening our swords, especially when it comes to this pandemic. Remember, in a pandemic, you need to have the latest news, the latest updates. So just ensure that each and every day before you go to bed, you've seen what is updated on COVID-19, on its management, on how it is being transmitted. Dr. Linus has just highlighted that COVID-19 is not just, it's not just, it's also an airborne disease. As most of us thought that it is just contracted through contact. So we have to be very key, even when we are doing our procedures. Let's not just assume that we're just doing a surgery. Remember that if you don't protect yourself, no one is going to protect you. And my fellow professionals, we have a role to play. We have a big role to play in care for ourselves and care for our patients. In a pandemic, remember again, we do not have an emergency. The emergency is the safe. And if you're safe, again, you'll be able to control even the spread of the disease. So I had a small overview of what we are doing in Machakos County in terms of preparedness. And maybe you'll allow me to share in a minute. So in Machakos County, we have 4 isolation centers. 4 isolation centers. One is in Machakos level 5. another one in Kinania, which is in Ativa, Kangundo, and Stadium. In the Machakos level 5, we have an isolation in a critical care unit, and we also have a transitional ward for the critical patients who are maybe suspected of COVID and not gotten their results, and they are waiting maybe for consultation. So a total bed capacity of 373 for isolation, and definitely in staffing we've had staff who have been infected with COVID. We've had a number of 14 of them. 8 of them have already been retested and turned negative. And out of the 8, 3 were admitted in some of the facilities in the country, simply because they didn't have an environment that would accommodate them for self-quarantine or self-isolation. But we also want to say that we are also lucky to have a lab that is also doing the test. The majority of the staff have also been tested. Again, this is very key. Remember that Dr. Lina said that the health workers can be actually the source of, especially when they are symptomatic, they can transmit this infection in a diverse way, from yourself to the patient to the colleague. You can imagine it's going to spread like a bushfire. We also want to appreciate that we also have PPE. We received a few from the COVID fund from Equity Foundation, around 47,520, which was in assorted form. We also had purchases from the county, around 2,000 pieces, and then the national government at 500 packs. We'd like also to appreciate that we've had an increment in staffing. We had a total of 96 staff under the UHC employment fund, and we really appreciate the country for that. And of course, it has not been smooth. I wouldn't say that it has been smooth, and we are not yet there anyway. We wouldn't say we are 100% in preparedness to this particular pandemic, but I would say we started from somewhere, we are somewhere, and we are heading, we are targeting at least a percentage of close to 95% in terms of preparedness. And in terms of psychosocial support, we are also visiting those professionals who have turned positive. We have a team which is consisting of psychiatrists, mental health nurse, psychologists, and counselors. So they've been visiting the home-based care staff. And for the other patients who have been also been managed under the home-based care system, we also have healthcare and especially the surveillance team who are visiting them. So I know it's a long journey that we need to understand that it might take long, but one point we shall be there. I have to repeat that we have to save ourselves so that we are safe to be safe and protect the other person. We need to work as a team, as professionals. There is no one in this particular pandemic who is above the other. We just need to hold our hands together and forge the way forward. I want to give my thanks to NNAK, to KMA, and the Clinical Officers Association for bringing this effort and ensuring that this partnership has actually been enabled. And of course, this is a step, especially when it comes to a relationship.
Thank you very much,
Thank
Jacinta.
you very much, Jemima, and I really appreciate it.
Okay. So before we finish, Dr. Linus, if you're still with us, there are some very interesting questions I want you to answer before you leave. There was one that was about, it was about reusing N95 mask and how long an N95 mask should be used. I thought that was a very pertinent question. And for Dr. Kathy, we have a question on what help support system does Jitenge have to the exposed? I think you wanted to say exposed. And yes, so Dr. Linus, you can answer the issue of reusing N95 masks and if there is a system for sterilizing N95 masks. And then Dr. Kathy, you can talk about the support system that the Jitenge app is having for those who are exposed. Asante sana.
Thank you, Jemima. Thanks for having me back. First, let me say, first I talk about the Jitenge. I know Kathy will talk more about it. The purpose of really sharing it out here is to ask all the association really to talk to their members about this, not really Jitenge, C4C, also inclusive of Jitenge. C4C is specifically for us healthcare workers. So I would really urge the KMA, Nursing Association, KCOA, lab, and everybody else as healthcare to really disseminate this information to all the healthcare workers. I know we'll be coming back again in more details so that we register and use it to really monitor ourselves. Otherwise, if we don't do that, then it will be of no use. It will be very difficult for us to really see the magnitude and what impact it has and what mitigation measures we need to put in place. The other thing I want to put across is that currently the Ministry of Health is trying to call back the health care workers who are affected. Please, we would like to get your support to get more information so that the data that I've shared, we can actually use it more. And I saw one of the person asking a question whether we can compare it with other countries. Yes, true. From other countries, we have that data. But I know in some meetings I've attended, we didn't have something to share like this from Kenyan perspective because the data that is generated at the EOC does not have specific interest, interest for the healthcare workers. It doesn't tell us was this healthcare worker trained? Was this healthcare worker having PPE? Did he know or she know how to use this PPE? So those are some of the things that we are trying, and I'm asking all of us if one of the ministry officials reaches out to you for more that information, please kindly may you respond, and that will really help us to put more measures to help ourselves. Back to the question, Nyawira. So the use of PPE from other countries, I know what they have done, like I would say like in India experience, is that they give healthcare worker, for example, N95, 7 of them. You use one per day, and the other one, you are given a very nice package to store it, and they put it in the sun, so that by the time you repeat it on the 7th day, it has been sterilized. So there are various methods of sterilizing, that is hydrogen peroxide. Some have actually used laser in terms of sterilizing this N95. There are studies that have been done to that effect. Now, in our setup, one of the drawback we have is that once you have sterilized it with whatever measures, even using hydrogen peroxide, we are not able really to test the integrity of it. So that becomes a bit difficult to talk about sterilization. But one thing that I would personally advocate, like the lesson from India, is if I have 4 of them and I can really put them in a nice polythene big bag. Again, polythenes, you know, from our laws, they are not allowed. You can expose it into the sun, and at least that from the experience other countries, it still maintains its integrity, and that you can be used. Now, in terms, there are 2 things, terms that are applied in terms of PPE and especially masks: prolonged use and also reuse. The use means is that I have worn the mask, and after finishing, I remove and do my other things and then come and put it again. That is reuse. Prolonged use is actually having it in the morning throughout the work period that you are in for 5 or 6 or so hours. So that is the 2 differences that we needed to understand. Now, prolonged use is allowed for at least 4 to 6 hours. This also depends, and again, that's why I said depends on the area that you are working. And that's what we are talking about, risk assessment. What area am I working in terms of, if let's say you are working in the ICU, doing a lot of sucking to the patient, then that really, reusing that will not be recommended because it will be really, really contaminated. And in the process of trying to put your mask again, you contaminate yourself and you get infected. So those are some of things that I would say. Now, have I answered? The other one was what? Because I seem to have forgotten.
Yes, actually, you have actually answered two of the most important questions. There was one more question about engineering controls, but I think you answered that one in the chat session. I want to give Dr. Kathy this opportunity to answer the question about how the Jitenge app is supporting those who are exposed. And someone else, Dr. Kathy, has asked about the requirements. I think it is to get the C4C application, yes. And then after that, Dr. Liz Gitau, if you're with us, you had a question for Dr. Kathy. Or Liz, do you want to go first and then Dr. Kathy can answer the three questions together? Karibu.
Thank you, Jemima, and thank you so much for this very, very timely CME on IPC. We have learned so much. I think my KMA people are just texting me how awesome this presentation is. So, and also for Dr. Kathy for C2C, I think for me, from a KMA perspective, is to ask, as associations, ourselves, NANAC, and also KCOA, how can we use this platform to be able to assist our members? Thank you.
Thank you very much. I was actually going to ask her the same. So Kathy, over to you.
Thank you very much. I will start with a brief description of what really Jitenge is and how it would assist. Just to give you a little bit of a background, we came up with Jitenge in the initial period where the Emergency Operations Center team was having to call every contact by phone. And every day they had to call these contacts to find out what their symptoms were. And once they figured out that they were symptomatic, then figure out how to manage them, take them for quarantine. And at the time, they were taking them for facility quarantine. But again, the people who are managing the facilities were only one person managing many, and they themselves are at risk. So the system ideally was to support the healthcare workers who are managing those who are under quarantine to reduce the face-to-face interaction. And so what the Jitenge system does is that when you're enrolled into the platform, then every day you have certain questions that you would need to answer, or certain, so you need to give your either your temperature if you have a thermometer, or you need to state whether you feel like you have a fever, and then the other symptoms of headache, are you coughing? Do you have a shortness of breath? And there are certain questions that you're asked. If you respond yes to any of those, a message is sent to the healthcare worker that is responsible for you. So it is a platform that was developed to support the healthcare workers that have a team of people that they're managing either under quarantine or because we're also at the border, the officers managing the borders with truck drivers who probably tested negative, but they're en route and they need to continue giving their symptoms, so that if they turn symptomatic, then some message goes to a healthcare worker who then picks that up and decides whether they're going to quarantine them or what kind of management they're going to provide. The reason why we integrated care for the carer with Jitenge is that we realized that there were a lot of exposures happening to healthcare workers, but very little support given to them. Or maybe there is support, but the numbers are growing. So how do we create a platform that will actually show? Because right now within Jitenge, you cannot tell out of the people being managed within the system, who are the healthcare workers and who are the public. And so we wanted to have it integrated with care for the carer. And then when they are transitioned into Jitenge, we know that we have this many healthcare workers, even by cadre. So we will know we have 5 doctors who are being managed within Jitenge. And then they can continue with their 14-day quarantine, just like everybody else, but at least we know how many healthcare workers are being supported by the platform. So the registration within the platform right now is done at you know, like I'll give an example, that like the home-based care, the people managing home-based care or have healthcare or have public or people within that are being managed in home-based care, they register them within the platform, and then the system takes it up from there and starts sending reminders in the morning. You have not sent your symptoms, or you know, whatever. You need to actually report every day what your symptoms are, so that the healthcare worker knows you're good for the next 14 days. Then after 14 days, the system drops you because you probably are okay, or the healthcare worker picks up from there. So that's how you're enrolled. Now, to answer the other question, in terms of how you can get your either the nurses or the doctors enroll into this platform, we work with the partners. You may have a database of healthcare workers that you would want us to put into, or to include in the in C4C, but a message would go to all those healthcare workers, because they have to, remember, they have to consent to use this platform. So they would then have to complete the registration. We would just require a minimum data set, maybe the healthcare worker's name, the phone number. And then after that, we can enroll them under, for example, the Nursing Council, for example, or KMA, for example. So while we enroll them on the platform, they would be registered under a certain group. So you, as the Kenya Medical Association, if you wanted to customize messaging or guidelines to your members, or you want to send communication to your members, you can do that specific to your members. But when there is general information that needs to go to all healthcare workers, that is crucial, either that they need to know from a national level, for example, that can go to all of them. So we just need to work with you. We can support you in whichever way to get as many of your members onto the platform, and then and we can continue supporting them. If you have any messaging, you would get access to the platform, and you can send the messages. You can put in whatever publications or guidelines you want to send. We give you access from a high level. You tell us who you want as an administrator, we support you, but you run with it. We would support you in the beginning, but after that, you can continue managing your members. We only come in if you have any challenges or you need us to support you in a certain way. But that's the platform in a nutshell. And we do hope that as many healthcare workers can enroll on the platform, so that we can support them in whichever way. We know that there is a lot of challenges out there. The platform is supposed to support them and make it easier for them to access the information they need. But even when they report some of these exposures, we figure out how we can continue supporting them to link them to care. We are not the healthcare workers, but we will link them to the people they need to be linked to. I hope I've answered all the questions, and it's over to you. Thank you.
Thank you very much, Dr. Kathy. Yes, you have, and be sure we shall be knocking on your door so that we are able to get as many of our healthcare workers enrolled on the platform. I have my president here with us today. I want to give him 1 minute to say thank you and to say bye-bye and close our webinar for today, and see you next Thursday. Karibu, Alfred.
Hello, good afternoon all. I just want to say thank you to all of us who have participated in this webinar. I hope it has been productive and educative, and it has added value to our response and management of COVID-19 pandemic. We shall be having similar webinar meetings and which have been organized by KMA, KMPDU, NNAK, and KCOA, and other partners. It's our wish that we will work together, support each other, be our brothers and sisters keepers during this trying time, so that we can give our best and protect each other. Otherwise, asanteni sana, Mungu abariki. Saimo, jambo sana. Nice to see you. Thank you so much.
Excellent.
All right, so thank you very much. CPDs will be sent to your various email addresses, and everyone who's asking for the notes, we shall be sharing the notes in due course. Asanteni sana, and God bless you.